Good afternoon, everyone. I'm Dr. Pranitha, consultant neonatologist from Cuddles Kondapur. Today, I'm going to talk about hypernatremic dehydration in neonates. So, I'll discuss the topic under the following headings. Hypernatremia is serum sodium more than 145 in babies, especially associated with dehydration with the weight loss of more than 10%. So, the incidence of hypernatremia in our country typically ranges from 1 to 1.8%, and in sometimes it can be as high as 5% too. The risk factors which are associated with hypernatremia being early discharge from hospital, ineffective lactation support, and insufficient milk production in the mothers. So hypernatremia is basically deficiency of water in relation to the total body sodium content. The total body sodium content may be either normal, high, or low, but it is most commonly because of deficiency of water. We classify into the 4 types. Mild hypernatremia is serum sodium more than 150, moderate is more than 160, severe is more than 175, and extreme is more than 180. Severe and extreme forms of hypernatremia are medical emergencies. Coming to the etiology, based on the volume status of the baby, it can be classified into 3 main types. Hypovolemic hypernatremia, which is most commonly because of inadequate breast milk intake, and the other causes being diarrhea, usage of radiant warmers, excessive sweating, renal dysplasia, osmotic diuresis, either because of hyperglycemia or because of diuretic phase of RDS, vomiting, and polyuria. Then euvolemic hypernatremia, where the volume status is normal, can be either because of decreased production of ADH, that is mostly central in origin, like central diabetes insipidus, head trauma, CNS tumors like craniopharyngioma, meningitis, or encephalitis. Then it can be also because of decreased or absence of renal responsiveness to ADH. So this can be seen in nephrogenic type of diabetes insipidus, extreme prematurity, renal insult, and medications such as ampho-B, hydantoin, and aminoglycosides. Then the third type is hypervolemic hypernatremia, which is the least common. Here the volume status is more because, the hypernatremia is most commonly because of improperly mixed formula, sodium bicarb administration, accidental overdose, or sodium chloride administration, primary hyperaldosteronism, and very rarely it can be because of high breast milk sodium content in mother's milk. So whenever the volume status in our body, like we have dehydration along with the hypernatremia, there are certain changes happens. One is the regulation by the kidney, by the heart, and by the CNS. So the first mechanism by kidney is by the secretion of aldosterone, renin angiotensin aldosterone pathway, where because of dehydration and decrease in blood volume, there is decreased blood pressure. This will stimulate the juxtaglomerular cells of kidneys. Renin is produced. This stimulates the production of angiotensinogen from liver. And from the lungs, there is production of angiotensin 1 and angiotensin 2, which acts on the renal medulla, causes vasoconstriction, and increases sodium and water absorption, and also potassium secretion. Then the second mechanism is because of ADS secretion. The high plasma osmolality causes osmoreceptor activation, which causes the secretion of the ADH hormone, and this causes water reabsorption from the kidneys. So this is how the water status is regulated. Coming to the pathophysiology of hypernatremia in neonates, the renal mechanism is also immature and there is decreased conservation of water. And because of the high body surface area, there is a lot of excessive insensible water losses. And there is no compensation because of thirst mechanism. And there is also lesser ability and maturity of the antidiuretic hormone system. Let's understand the concept of tonicity and osmolality. So tonicity is the osmotic pressure across two solutions which are separated by a semi-permeable membrane. So here the solutes or osmoles which do not cross freely across the membrane contribute to the tonicity, like the sodium or the glucose. Whereas osmolality is because of the total concentration of both penetrating as well as non-penetrating solutes. So in addition to sodium and glucose, urea also contributes to the osmolality. Now, when the tonicity and osmolality are normal, there is free passage of water across all the across the plasma, ECF, and ICF. But in case there is dehydration with uh, hypertonicity in the plasma, to preserve the intravascular volume, there is movement of water from the intravascular space into the cells. So there is cellular distortion and there is cerebral cell shrinkage. This leads to intracerebral bleeds, seizures, and irritability. And in this case, if the dehydration persists for a longer time, there is chronic dehydration. There is a production of idiogenic osmoles in the brain. And during this time, if we are providing a lot of hypotonic solution, there is movement of hypotonic fluid into the cells. So there is swelling of the cells, which leads to cerebral edema, encephalopathy, and cerebral pontine myelinosis. Coming to the symptoms of hypernatremic dehydration. So babies may have poor feeding, fever, reduced urine output, exaggerated jaundice. Sometimes it might reach to the exchange levels, seizures, irritability, lethargy, stupor, coma. So in the history, we need to take a detailed history about the fluid intake, what feeds babies on, how much is the breast milk production, what are the losses, is there a lot of diarrhea, a lot of urine losses, is there any insensible losses from the skin, are there any midline brain defects, and what are the drugs the baby is on, is the baby is on any Lasix or desmopressin or any hypertonic fluids are being administered. Then coming to the differentials of seizures in babies with hypernatremic dehydration. So seizures can be either because of cerebral edema, CSVT, cerebral hemorrhage or infarction, or there can be associated sepsis leading to meningitis. And then coming to the examination, what are the signs we see? Usually the dehydration signs are not very evident in a baby with hypernatremic dehydration. Shock is usually a late sign because intravascular volume is preserved. There can be AKI, and we have a doughy feel of skin, and there can be certain neurological features like stupor, hyperreflexia. Coming to the complications, hypernatremia can lead to AKI, metabolic acidosis, acute liver failure, DIC, intracerebral hemorrhage, cavernous sinus thrombosis, iliac vein thrombosis, sugar fluctuations either in the form of hyperglycemia or hypoglycemia, and hypocalcemia is also pretty common. So why do babies do not show signs of dehydration in spite of the excessive volume loss? Because hypernatremia causes increased hypertonicity and this causes fluid to shift. So from the intravascular space into the extravascular space. Hence, though the intravascular volume is much less, the dehydration signs are not very apparent. And when can we do rapid correction in cases of hypernatremic dehydration? If hypernatremia develops rapidly, like the baby is administered some accidental overdose of sodium chloride or improperly mixed formula or sodium bicarbonate, in such cases, there is no production of idiogenic molecules in the brain. So here the risk of brain edema is less and hence we can do rapid correction of the hypernatremia. But in cases of chronic hypernatremia, we need to decrease the sodium levels by 0.5 milliequivalents per hour. That is at least only 12 milliequivalents per day. Because in cases of chronic hypernatremia, the brain starts producing idiogenic molecules to maintain the cell volume and tonicity. And if we cause rapid correction in these cases, there is abrupt fall in the extracellular tonicity, resulting in the movement of water into the brain cells, which have a relatively fixed hypertonicity because of the presence of osmoprotective molecules. This leads to cerebral edema and further complications. Investigations. So initially, when there is severe hypernatremia, we need to do electrolytes levels, calcium, septic screen to rule out infection, renal function tests like creatinine, blood urea nitrogen, ABGs, plasma osmolality, neurosonogram. And later, if there is neurological features, we also may need to do MRI brain with MRV, EEG. Coming to the management. The principles of management being avoid rapid decline in serum sodium and also avoid cerebral edema. So first is the emergent phase. In the emergent phase, we usually give NS bolus 10 to 20 ml per kg, and the fluid used for bolus should have the tonicity with the sodium levels 10 to 15 less than the patient's level. So if the baby's sodium level is less than 175, we administer NS. But in case if it is more than 175, we also add some amount of 3% NS to the NS to make it so that the fluid has the sodium level of 10 to 15 less than the patient's level. But the bolus has to be administered only if there is hemodynamic instability in the form of shock or anuria. So we usually start with a single bolus. Double bolus is usually not preferred because it can lead to cerebral edema. Unless there is hemodynamic instability, that is persistent shock, second bolus need not be administered. Then after emergent phase, the next phase is the rehydration phase. Here we are going to do slow correction of the dehydration status. In cases of mild dehydration, it is done over 24 hours. In moderate dehydration, over 48 hours. In severe, over 72 hours. And in extreme, over 96 hours. So this is calculated by plasma sodium minus 145 by 50. So that gives the duration over which we need to do the rehydration phase. And in 24-hour correction, we can give the first half of the IV fluids in 8 hours and the rest half in the 16 hours. So coming to the calculation, first we need to calculate the maintenance fluids. So the maintenance fluids is usually 100 ml per kg per day. So this we calculate based on these three things. First, insensible water losses, which amount to 30 to 40 ml per kg. Urine output, which is 50 to 60 ml per kg. And stool output, 0 to 10 ml per kg. So all this corresponds to a total of 100 ml per kg per day. But if the baby is anuric, then the urine output need not be calculated. So in that case, the total maintenance is going to be only 40 ml per kg. But if the baby is under radiant warmer, then we are going to add an additional 20 ml per kg to the maintenance fluid. So what is the type of fluid used in cases of mild dehydration and moderate dehydration? We can still manage with feeds, but in case if we are administering IV fluids, in cases of mild dehydration, we need to give 5% dextrose with 0.2% of NS. In moderate dehydration with half DNS, severe dehydration with DNS, and in extreme dehydration, we need to add 3% NS to the DNS. So coming to mild dehydration, we are going to correct it with feeds or in some cases by fluids. In cases of moderate dehydration, we are going to give enteral fluids for normal maintenance, either with EBM, and in case if the EBM is not adequate, we are going to supplement with formula. And the deficit correction is done over 48 hours. So if there is rapid fall of sodium, we need to decrease the IV fluid by 20%. And we need to keep monitoring the electrolytes, urea, and RBS. In severe hypernatremia, we need to manage the baby in the ICU, replace the deficit over 72 to 96 hours, and strictly monitor the input-output chart hourly, weigh the baby at least twice a day, monitor the GCS, do electrolytes initially first every 2 hourly for the first 6 hours and later every 6 hourly. Monitor the urea and also monitor the blood sugars. Blood sugars again every 2 hourly initially. So let us see some concepts in the management of severe and extreme hypernatremia. So first we need to calculate the free water deficit. Free water deficit is the amount of water which is free of solutes, which dilutes the sodium back to normal when added to the body. So how do we calculate this? Free water deficit is calculated by 0.7 into body weight into sodium current minus sodium decide minus 1. So 0.7 is in neonates, it is taken as 0.7. That is because 70% of the body weight is water. Whereas in babies more than 1 year of age, we can take this as 0.6. So if we calculate the free water content of IV fluid, this is done by 1 minus IV fluid sodium by serum sodium. So for example, if the IV fluid we are taking is DNS, it has a sodium of 154. And if the baby's serum level of sodium is also 154, then the free water content comes by is 0% free water. But if the serum sodium is 195, then 1 minus 195 by 154 will be almost 21% of free water. So in cases of babies with very high serum sodium of 195, if we give even NS with serum sodium of with the fluid sodium of 154, still it is providing very high quantity of free water. So if a baby with serum sodium of 195 is given a large amount of NS to restore the volume status, the serum osmolality will fall, leading to cerebral edema and death. So to calculate it simply, we can calculate it by the following formula. The amount of free water required to decrease the serum sodium concentration by 1 milliequivalent is 4 ml per kg with moderate hyponatremia. And it is 3 ml per kg when the serum sodium is as high as 195 milliequivalents. So the free water required in cases of moderate dehydration, we'll calculate by weight of the baby into 4 ml per kg into 12 milliequivalents. That is the amount of sodium we need to get down in 24 hours. So that will be current weight into 48 ml per kg. But in cases of severe hypernatremia with the sodium of more than 175, the amount of free water required to decrease the serum sodium by 12 milliequivalents over 24-hour period is calculated as current weight into 3 ml per kg into 12 milliequivalents. That is weight into 36 ml per kg per day. So this is again the percentage of free water which you are calculating in the IV fluids. So I'll skip this slide. Now, if the baby has severe hypernatremia, that is sodium is more than 175, then as discussed, we need to add some amount of 3% NS to the fluid to have the fluid's sodium levels at least 12 to 15 milliequivalents less than the serum sodium. To get the amount of 3% NS to be added to the NS, we use this formula 1000 into desired sodium minus 154 by 500 minus desired sodium. This is the ml of 3% NS to be added to 1 liter of the NS. So now let us consider one example. We have a newborn who is born at term gestational age with a birth weight of 3 kgs. There is 20% weight loss and the serum sodium is 182. The baby is anuric, hemodynamically unstable, and the current weight is 2400 grams. So here, since the baby is anuric and also hemodynamically unstable, we are going to start with a bolus to rapidly correct the hemodynamic status. So we are going to give a bolus of 10 ml per kg. Since the baby's weight is 3 kgs, it is 30 ml. Next, we need to give maintenance fluids. But here, since the baby is anuric, the total amount of maintenance fluids we are going to give is only 40 ml per kg. So 40 into 3 will be 120 ml, which should be given over 24 hours. But in case if there is also radiant warmer, babies under radiant warmer, we can add an additional 20 ml per kg here. Then we'll calculate the free water deficit. That is 3. Since it is hypernatremia more than 175, we are going to take free water deficit as 3 ml per kg. So weight into 12 into 3 ml per kg. That is 108 ml. This should be given in 24 hours. So for 3 days, it is going to be 324 ml. And the amount of deficit, baby's weight is 3000 grams, current weight is 2400 grams. So the deficit here is 600 ml. From the 600 ml, we are going to minus the bolus given. So there is 570 ml. This 570 ml has to be replaced over 3 days. Now the total amount of fluids which we have to give over 72 hours is the free water deficit plus the deficit of baby. So 108 into 3 plus 570. So this 894 ml we need to give over 72 hours. So that is 12.4 ml per hour. And the type of fluid we give is NS, and we are going to add the 3% NS in the fluid. So this correction is done into at least in 3 to 4 days. Now let us consider a preterm baby. So premature babies also usually have hypernatremia after day 3, day 4 of life. So in these cases, it is most commonly because of insensible water losses. So what is the management strategy here is we are going to decrease the insensible water losses. For that, we can increase the humidity up to 95%. We need to keep checking the daily weight at least twice. Then fluids, we are going to increase in the steps of 20 ml per kg usually, but here because there is excessive weight loss with hypernatremia, we can increase up to 30 ml per kg. But also keep in mind about the PDA status of the baby. But though there is hypernatremia, the total body sodium may be normal, and hence we need to give the normal maintenance of the sodium level, which is usually 3 to 6 milliequivalents per kg. But before supplementing, we should also remember that the sodium is also being administered in the form of heparin infusions, and some antibiotics may also be containing sodium. So we have to detect that sodium also. So what are some of the common mistakes which we do while managing a case of hypernatremic dehydration? So usually hypernatremic dehydration is also accompanied by hyperglycemia, but we need not treat this hyperglycemia. Try to maintain GR at a minimal of 4, GR of 4. And in case if the hyperglycemia still persists, only then we need to start on insulin infusion. Also, do not treat the metabolic acidosis, which is associated with the hypernatremia, because again, sodium bicarbonate is again going to contain sodium as well. So be cautious of that. And whenever we are giving bolus, try to avoid giving the second bolus because it may precipitate cerebral edema. And in case if there is cerebral edema, we are going to manage it by giving a 3% NS bolus of 5 ml per kg. Okay, thank you. You know.